Good evening, everyone. My name is Jim Mancini. Welcome to our first presentation of 2019 in our Autism 200 series. And I want to apologize if anyone was looking forward to what Rafe Bernier and I have been doing for the last couple of years, where we, sort of dress up as newscasters and do a kind of newscast of talking about this. Rafe and I, our New Year's resolution is to actually check each other's calendar and decide when we're available, because he's somewhere across town doing something kind of similar, talking to some people. So I wanted to welcome everybody, and I also wanted to welcome everybody who might be watching from home or from elsewhere. As you know, we have Facebook Live is a way to connect and view all of our Autism 200 and 101 classes here, and also welcome to you brave souls who come out and sit here in person. So it's nice to have people here too. The purpose of this particular talk is to talk a little bit about what have we learned over the last year, what's happened over the last year, and also take a little look about what might be coming up in 2019. So I'm very excited that we have 4 different speakers who are going to take about 20 minutes each and share some information. We have Dr. Sara Webb from the University of Washington Department of Psychiatry. And then we'll be followed by Amy Carlson, who is a nurse, and she's from the Washington State Medical Home Partnerships Project. And then Dr. Fred Shic from the University of Washington Department of Pediatrics. And then finally, Arzu Forough from Washington Autism Advocacy Alliance. We have 2 folks who are going to be talking about research, and then 2 folks who are going to talk about more sort of community activism. And if I could take a moment and just kind of reflect about this last year, the word that continues to pop into my mind is this word inclusion. Okay, and 1 year ago, I felt like there was just a ton of stuff going on in regards to the inclusion. It seemed like there were billboards up, and there were organizations, and there was so much talk about how we were going to encourage community inclusion for people with autism and developmental disabilities. And a lot of it seemed to in retrospect, seemed to be really aligned with our, we were lucky enough to have the Special Olympics National Games here in Seattle. And after that, the conversation kind of stopped, and I just, the purpose of me mentioning this and what I've asked each of our presenters to talk a little bit about tonight is, what does inclusion mean to you? And we'll kind of talk a little bit about it at the end. But I think that it's important to continue to talk about this and not let it kind of fade into, because there's not an opportunity like the Special Olympics to talk about it. It's something that we need to continue to talk about, and we will continue to talk about. So without further ado, I will introduce Dr. Sara Webb.
Thanks, Jim. Thanks to all of you who could be here in person today, and those of you who are joining us remotely. I hope you are having a good evening at home. I'm going to give you a little bit about my background before I go and talk about what has really interested me in the work that's come out this last year. So I'm a child psychologist, an experimental child psychologist by training, and my research program at the University of Washington since 2001 is really focused on a lot on understanding risk for autism. So understanding which infants and young children are more likely to develop autism symptoms, and what does that mean for providing them the correct treatment over time so they can make the growth and learn in the best environment for them. And when I think about what Jim had asked us to do inclusion, I might think of it a little bit different from a research standpoint. In the studies that I focused on today to tell you about that came out last year is really think about large studies and really getting out of the kind of work that we do in research where we find samples of convenience that either live close to us or are the people that we already know who have been in research in the past. And these studies that I'm going to highlight are ones that have really brought people together across the United States, multi-site studies that really have, I think, what is a diverse representation of individuals and families that have found themselves affected by autism or have children that are at risk for developing autism. So When I think about risk for autism, so risk for an individual or a young child developing autism, there's lots of things that we can think about that might be causing that infant to be at elevated risk for developing symptoms. And this research has really gone on in part of the Baby SIBS Research Consortium sponsored by Autism Speaks and Autism Science Foundation. So it's a consortium of 26 sites across the United States, plus the sites in Canada and Europe, and we come together every year to think about how can we both better understand why children develop autism, but how can we pool together our data and resources to really understand, again, individual risk and group risk. And so sometimes we think about things like we think about what are the infant behaviors or things that we see in really young kids prior to sort of that diagnostic age, or we think about earliest diagnosis is at 2 to 3 years of age, but we know in the community the average age of diagnosis is 4 to 5 years of age. So how do we think about maybe things that we can find really early on in terms of behavior that might sort of set some red flags that would bring kids attention and get them into some supports and their parents into supportive environments early to maybe change their trajectory. And the other one I want to think about are some of sort of the medical and biological risk variables that might be there. And that's some of the work that Fred Shic and I are doing right now at Seattle Children's, where we have a new study looking at infants who are at risk for autism because of family history or because they were born at low birth weight or premature. And then I think the last one is about measurement of risk, is that how do we think about screening children and working with families and pediatricians to really understand and help them get the supports really early in their community. I'm not going to speak about genetics or environment, but I'm happy to answer questions about those areas as well. And we know from work that I've done and Fred Shic has done and others in our community really thinking about social attention markers. So we know social is a big children with autism have difficulty in the social domain. And we have a lot of research to suggest already that children at 6 to 12 months have decreased attention, and they're not looking at the faces of other things in their environment. And my work has showed altered time to learning about a face and decreased social brain activity to faces. And we know that by 12 to 14 months, we see these early sort of measurements we can do in the lab are related to poor eye contact, lack of attention to others, and difficulties with joint attention, which then also predict a diagnosis of autism. So what's new? We published a lot of this work between 2015 and 2017. What's new in the community? And I think that what we saw last year in terms of other research coming out is not just thinking about autism as a social disorder, but what might be other risk factors we might see in infants that might help us understand which infants are at risk and what might be going at risk. And so Becky Landa at Kennedy Krieger has some really great work and has done this over time, looking at motor skills as related to language. And we often don't think about how we move or how we sit or reach for things as being related to first words, but there's pretty good literature within neurotypical infants that these things are related, is that as you begin to move in your environment, you start to want to name things and you're looking at people. And so motor is actually something we're really good at. Pediatricians are really good at picking up on motor delays very early. And we also know that these motor skills in infancy are related to object exploration, social communication, and social skills, things we know kids with autism have difficulty with. So in Becky's work, she had a sample of 140 infants from around the Baltimore area, very nicely diverse sample that she brought into it in terms of background of race, ethnicity, and socioeconomic status. And she looked at 6-month scales. So took something, the Peabody Developmental Motor Scales, which is a standardized task. And this is another thing I love. These are things that translate really well to the community. These are resources pediatricians and birth to 3 providers have at their hands. So again, thinking about how we include more people in thinking about risk and screening, looking at some of these research studies that really are things that we can generate, that can go out into the community pretty quickly. And one of the things she looked at is some of the things I think as parents we also write down about our kids, right? How kids can grasp things in their environment, how they do visual motor integration, reaching and getting something. And what she found is that looking at kids who are at low risk for autism and then these children that go on to develop autism at 3 years of age, gross motor skills, sort of big stationary, kind of how you kind of stand and, how the kids when they're first starting to stand at 6 months of age and pull themselves up, or when you hold them up with your hands and how well they can kind of maintain that upright position, is really was different in those kids who went on to who are at higher risk for autism and to develop autism later. And this visual and they were also related to language ability. So things that we weren't thinking about things that we could measure really well in infants, things that pediatricians can measure well, were actually showing some risk for being delayed in both language and in social skills later on. And so this is a good reason why thinking about this study in terms of what we know, that some of the stuff we do right now in understanding social attention and perception in young infants at risk is based in the lab. We have eye trackers and EEG systems, and those aren't things that pediatricians or parents or birth to 3 programs have in there, but doing something like the Peabody and looking looking very carefully at how a child's early motor skills are developing is something that really could translate into helping families look at screen and think about risk very early on. So that was a study Dr. Landa's work is also incredibly influential and very just really groundbreaking, and she's got a lot of interventions that are also coming out of this, thinking about how motor integration is also possibly an area that you could intervene prior to symptoms of autism developing. And so thinking about the other parts of autism, so again, not just the social design, but we know with the DSM-5 that comes out, we're now, having sensory problems is actually counted. We look at sensory problems in a different way with the new diagnostic criteria, even though we've known individuals with autism have really hypo and hypersensory responsivity. This is another one about early toddlers at risk for autism that comes out of this group. And so this became important, thinking about how do we, now that we know that DSM-5 sensory symptoms is part of this DSM-5 criteria, how early should we be looking for sensory disruptions? And this, again, a very large study. This is 331 infants at high risk for developing autism because they have an older sibling with autism, matched with 135 low-risk controls. This comes from 5 sites, I think, across the U.S., so again, representing a pretty diverse set of infants and families. And they used, again, another questionnaire that is available widely, and used it at 12 months of age in these infants. And they found that children who were later diagnosed with ASD had higher sensory hyper-responsibilities and tactile responses. So they were more responsive really early to the sensory information in their environment. And interestingly, when you look at, I think that this is the hyper responses right here, and way over here on the very right-hand top one, you can see that it actually goes up over time. So these kids were high to start with at 12 months of age, these little high-risk infants that developed autism or diagnosed with autism later on, and they got these sensory symptoms, they became more hyper-responsive over time. So it's actually looking at that trajectory. They stayed high, they started high, and they stayed high. What's interesting, and I know many parents with autism write this, is sometimes your kiddos and the individuals with autism are really hyper, and sometimes they're really hypo or lat responsive. And this was an interesting fact that they saw that in the questions that were marked under responsivity, responsivity, excuse me, at 12 months of age, kids look very similar regardless of what group they are, but those kids that developed autism also began to show more hypo-responsiveness. So that's something that you wouldn't think of. Like, we tend to think of kids being sort of unified and that you'd be either really responsive or really under-responsive. But what they're showing is that over time, between 12 to 24 months, these kids that go on to develop autism are having these domains that are inconsistent, where they're really high in some domains and really low in other responsivity, which I think every parent with a child with autism reports, like, oh, my child really reacts to this and seems to ignore this, and that's a really unique profile in autism in contrast to other things. So really this group is showing that this is happening really before, again, many times children are receiving a diagnosis. So again, thinking about and having pediatricians and others really think about how is the kid responding in terms of either increased and decreased, and you might actually be looking for kids to be doing both of them, and that might be an okay pattern. So instead of saying, oh, you're high here and low here and it averages out so you're fine, we might say, oh, look, you're really having these extremes, and that might be a sign that we need to do some further follow-up. And this is part of the infant brain imaging study, IBIS network, and the University of Washington is actually one of the sites here that contributed. So there are families in our community that have contributed to this data. Again, thinking about this issue about diversity and inclusion, it's a questionnaire, and it's a questionnaire that's widely available. It's something parents can fill out. It's sort of a low-demand thing, and so thinking about how research can translate into clinical practice very quickly. Here's another one that came out, large study, easy to understand the results, looks pretty interesting, could go into sort of thinking about in our clinical practices pretty quickly. So this is an area that Fred Shic and I have become very interested in. We also have a very large, our neonatology group at the University of Washington in Seattle Children's is renowned for their work with very low birth weight preemies and early preemies. And so we have a very large research program outside in preterm infants. But it's been a little inconsistent about whether or not being born premature or low birth weight actually carries risk for autism. Other than, we know that kids who are born very early are at risk for other sort of general developmental disabilities or have increased risk for ADHD and specific learning disabilities. But the relationship to autism has been a little less clear. Children who are born premature often don't do very well or fail at autism screeners, but don't really seem to often have the previous literature has been really inconsistent if that means there's actually elevated rates of diagnosis. So this is a big issue because, as I said, 13 million infants are born premature each year across the globe. That is a huge population, and we know for our own rates in the United States, we have made very little progress in some areas of our own country in terms of reducing the rates of premature infants. And there are some states in the United States right now that have increased rates of premature birth, particularly among certain racial and ethnic minorities. And 1 in 10 infants in the U.S. are born premature. So this is a really high risk group. This is a group that's high risk for having sort of poor developmental outcomes. And the question is are they at risk also for thinking about autism as something we should be screening these infants for? So this is a meta-analysis. And what essentially means is they took 18 studies. So 18 studies, but different groups. And so they brought together a sample of over 3,000 preterm infants to pull this together. So when you think about diversity and how that represents a lot of premature babies in a lot of communities across the U.S. And you can see some of these 18 studies on these graphs. This comes right out of the paper. The circles are bigger for studies that have bigger sample size. So you can see some of the studies are really tiny. They have small sample sizes of about 50 kids, and some of them are really large with samples of 500. Now, if you imagine you're reading those 18 studies, how do you think about a study that has 50 preemies versus a study that has 500 preemies? And they've had a little bit of inconsistent results. So these authors brought this work together and looked at babies that were born between 25 to 32 weeks of gestation age and all under 1,500 grams. So they're premature and they're pretty small for birth. For size, and they followed them up because it's a meta-analysis of lots of studies. There's lots of different methods in there. So some of the kids were 1.5 years and some were 21 years of age. But one of the nice things that they did is every study they included actually saw the kids in person. So this isn't doing it. They only included studies that had in-person evaluation. They weren't taking them from other records. So they have some pretty, eyes on, and they could say that there's a lot of standards about what, how the diagnosis would mean. It was pretty very interesting to see the diversity of diagnostic tools as we know that are out there. But again, they had eyes on on these kiddos. And then so looking at the prevalence of ASD, so we know that autism spectrum disorders has a prevalence of about 1.5% in the general population. It was 7% in premature infants. So again, that's really suggesting a much more elevated rate than we thought was coming out of here. And if you could see in these graphs, this is showing you gestational age. So over on the right-hand side of those babies born at 32 weeks and over on the left of their 24. And you can see that like the earlier you're born, there's more likely to have higher rates of autism. So the 7% is an average across all of these studies. And as you get more towards 32 weeks and over, that percentage of kids starts to go down. And that's same, and the earlier you're born, the smaller you are. So it's a little hard to disentangle how early you're born from what size they are, but they think it really has more to do with how early than what size, although we can debate the science of that a bit. So I think that this is a really good number. It's a good number, again, to go back out into our communities and think about other ways that we can begin to work with other communities that have kids at a risk, think about other populations that we should be inviting us and joining into our research, into our clinical practice about outcomes for kids with autism. Outcomes for kids with premature in terms of autism. And so this is, we're going to skip this one. We're going to go, the last one I think really speaks to this issue of inclusion. So we know that children with autism spectrum disorders from low-income minority families or those with limited English proficiency are diagnosed at a later age or not at all, right? We have communities that do not get the screeners that are available. And often individuals in these communities might have limited exposure to what autism is, or just the understanding of how we use some of the terms comes from a really Western medical perspective. And so even the words we use and what we might be expecting of babies to do at certain ages may not sort of resonate with some of our communities. And so this group really created a developmental check-in and published on this, which I think some work that's going on across UW and Seattle Children's and other places is thinking about how do we improve screeners so they work for all communities, right? And how can you make screeners so that parents understand what you're looking for and can talk about them? Because writing something down sometimes doesn't always click. You want to see the examples. And what they did is they created a screener that included pictures and very low language requirement, right? So this is a prompt. This is a prompt where it says, does your child respond to name? So the question is respond to name, right? And just a yes or a no. This is one that is very common on MCHAT and other screeners. Failure to respond to name is highly predictive of an autism diagnosis. And this is the picture that goes along with it. And when they took this screener out into federally qualified health centers, so again, working with populations that are normally not getting a lot of screening or might have sort of low resource communities, and daycares, so thinking about our daycare providers as a potential other avenue for really expanding screening. Lots of kids are in daycares and different kinds of daycares. And these kids were 24 to 60 months, so right at that good screening age, right? Right when we are going to begin to see and have the ability to make the diagnosis, and created this developmental check-in. They have pictures in line drawings and photos. They have diverse samples of images of children, so it's not just, it's lots of different pictures of different kids and different parents. It comes in English and Spanish, and it's based on the known flags from the ADOS and the STAT. The STAT is designed by Wendy Stone here at the University of Washington, so two great diagnostic tools pulling that in there. And they really went out and ran this type of screener and began to really said, this is how you would use it. Here are the cutoffs for being predictive of autism. And it did pretty well. It was, in terms of being sensitive, telling us which children actually would end up getting a diagnosis of autism and which children did not have autism, because you want it to do both. You want to find the kids that had the autism, and you don't want to accidentally give a diagnosis to a child who doesn't have it, right? And it did pretty well, aligned with other screeners that are out there, so equally well. And it was actually really, really liked by the families. These were families that had not experienced kind of this level of screening and attention. And so I think that thinking about how we can take these things when we talk about that motor domain, that sensory domain, thinking about other risks like prematurity, that, how we translate those into our clinics and providers. Here's another example. Have you take that even farther? How do you not just create a questionnaire that someone's going to have to take home and fill? How many of us filled out those little things with the circles where it's hard to see what you're really answering or think about it? And to turn it into something like this that works at the level that we want it to do, where it's out in the community and qualified health centers that aren't going to have potentially a lot of experience with kids with autism. It's out in daycares, again, where providers might have different levels of knowledge. It's working for these families who are English and Spanish speaking. And it does as well as some of our sort of more text-based screeners who we've been using a long time. So I don't think it replaces, but I think it goes in a really great direction, and we can think about how we can make this even better, and Fred's doing some work in this area, thinking about how do you create dynamic videos, that now that we have this ability to share stuff on Facebook and share these videos, how you might be able to even make this work better by showing an example of a child not responding to her name and a child responding to her name, and you can say, is this one of these more like my child or another? And Fred can talk about that work. But I really liked this because, again, thinking about that, how do we go out and take our results and really think about them in the communities that can best make use of this in terms of early risk for autism, and bringing more people to be aware of the disorder and be able to really screen for it or think about it, and then potentially that gives us an opportunity to work with families in the earliest stages of some of the symptoms. So those are the things that really excited me today. They weren't a lot of things that were super novel in terms of the research that came out in this area in the last year. They weren't like, I would have never expected that, but they were really large, solid studies that took a body of work and really has, put an exclamation point on it. And I think that's really important as we think about the translation of our work. So when we think about these, the slide I ended up not talking about is asthma and immune system problems, but when we think about these issues about how we might be sort of thinking about risk, adding more things in terms of our repertoire of what to look for in infants when we can put our eyes on them, and more things about how do we get families and community providers to, to really work with us and evaluate their children so they can get the best clinical response they can and the best outcomes. So those are the things I really liked from this year, and I'll turn it over to Amy Carlson.
Come on up, Amy. I just want to make an announcement. So I neglected to mention earlier that we're going to definitely have some time for questions, but what we're going to do is we're going to save the questions until the end. We'll have a nice little time. So go ahead, Amy.
Hi, I'm Amy Carlson, and it's a privilege to be here and talking about this work, although it's kind of weird because I don't know who I'm talking to, and so just bear with me. I'm going to attempt to talk about the school medical collaboration that's happening in some rural communities across Washington State to get children assessed for autism locally. And it's a really, really cool project. Let's see if I can figure this out. So just to introduce myself, I'm a nurse by trade, and I am on several contracts at the University of Washington that work on family-centered care and care coordination and autism. Oops, wrong way. And so support for this work comes from the University of Washington LEND program, the Department of Health, and also the Washington State Medical Home Partnerships Project, and specifically a federal grant that is called the AS3D grant that's housed at the Department of Health, and it stands for Autism Spectrum Disorders and Other Developmental Disabilities. And that grant's funding a lot of this work that is trying to strengthen community systems integration and increase access to interventions in rural communities. So as we look at the picture of the state, statewide, in the next 15 minutes, I'm going to attempt to, break down 10 years of work that we've done across the state. I can't believe that we started all this work in 2009. And the project started in 2009 when the Washington Autism Advisory Council was looking at how they could work on the long wait lists at the multidisciplinary diagnostic centers like Seattle Children's and Mary Bridge and the Autism Center, UW Autism Center. And as we know, back then, the rate of autism was 1 in 200. Now it's like 1 in 57 or 56. And the wait lists are still as long. But we've made some really incredible gains in rural communities in trying to make this more equitable to people that aren't necessarily able to get to the west side. So if you look at the pink communities are ones that have participated in what we called a community asset mapping project. And that was begun to kind of look at these long wait lists, and what we did was we went out into rural communities that were able to bring together a coalition of people that are interested in working with autism, and that was the schools, the pediatricians, early intervention, parent-to-parent, public health, all the different entities that see children with autism. We brought them together and did a facilitated half-day meeting in their community to talk about what are the strengths in your community around assessing and looking at early identification of developmental delays as well as autism. What do you have in your community in terms of awareness and resources, and then what are your challenges? And it was interesting, in all the communities that we've done, the two priorities that come out were we want roadmaps to services so we can figure out where to send our kids in the community, and we want diagnostics locally. So no matter what community we went to, that's where we ended up. So that, the I want diagnostics locally part spurred the Lewis County Autism Coalition on, And so we did the facilitated meeting with them in 2010. And I think around 2011 or 12, we started meeting with them. And because one of my superpowers is community organizing and facilitating, I was able to go down and be part of this work group to kind of look at, they had support from Mary Bridge and Seattle Children's and also the University of Washington to kind of look at, I think you guys can diagnose these kids that are very straightforward. They don't have to come to the multidisciplinary centers, and they don't have to wait for a year. There's a way that we can work this out. So we had several meetings. It probably took 2 years to get everything going. But during that time, I had access to some graduate students up here at the UW that were psychology students, and they came down and helped me to create a tool for this community that could be shared with the parents and all the different, the early intervention or the schools or the medical providers, anybody that had eyes on this child could fill out this tool. And it's just a one-page based on the DSM-5, kind of the checklist. And then they would collect that as well as their records, and we could do like a virtual multidisciplinary assessment. So it all started in Lewis County, and what it became called was SMART, School Medical Autism Review Team. And these were actually teams that came together, and it's expanded from Lewis County on to Pacific, Greater Grace Harbor. We've got work going on up in Whatcom, Skagit Island. Cowlitz is forming. There's also some work forming in Benton Franklin. They have diagnostic services in Yakima, and they also have diagnostic services in Chelan Douglas now. So it's been amazing work, and we'll kind of look at a little bit of how that all works. But even for those of you on the phone who are like, well, it's not in my community, and I don't even live in Washington State, but I'm going to attempt to kind of go through this whole process, but my contact is at the end, and if any of you, if this piques your interest or you're interested in kind of figuring out who your people are in your local community, if you live in Washington State, you can contact me, and we can work on that. So the SMART process goes like this. The family shares either with their pediatrician or the schools or the early intervention that they have a concern about their child. And whoever they share it with talks about, well, we have this program, it's called the SMART Team, and it's a way for us to kind of gather this information here locally in your community. And so they write a referral, or they send it to the SMART coordinator. And that person looks different in each community. Lewis County, their SMART coordinator is actually a nurse that's paid by the pediatrician practice. In other communities, they're community health workers that work for the health department, or whatever the one community has a grant-funded position right now. And the way that's most effective is that the SMART coordinator meets with the family in person for an hour, and they sign like a memorandum of understanding to be able to share records. They get the SMART tool. They make like 5 or 6 copies to have the parents actually fax or send to the other providers that have worked with this child, and then the parent goes and tries. With the help of the coordinator, helps them, gets all the records together that they might try to do if you're referred to Seattle Children's or the UW Autism Center. That work is kind of done there, but we're doing it locally in the community. Once they get all the paperwork together, then the SMART team sits down and looks at all the paperwork, all the assessments, and says, okay, this person really doesn't have autism. There's something else going on, so let's refer them on to back to the school district or somewhere else, parent to parent, or somewhere else for them to get the services they need. Or, yes, they have autism, or maybe they have autism, and so we need more information. And so if you need more information, then some communities have worked out where like there's somebody in the community that can do an ADOS or a STAT, and they can get those records. And then ultimately they bring everything to a center of excellence, and I'll tell you what that is in a minute, to make it either to make a diagnosis or, well, ultimately you get a diagnosis of autism from a center of excellence. And if you don't get it, I mean, so then they would, you know, write their prescription for ABA. They would be able to give you that diagnosis, and then they refer you on for services. So anyway, that's kind of how it looks. Let's see here. What I talked about for a minute. We're going to digress for a minute and then come back, because like I said, we're flying through 10 years. So if we digress a little bit, to get off topic, in 2012, due to some amazing advocacy of Arzu, which you'll hear about later, ABA became covered as a benefit under Medicaid. And so now we not only had these long wait lists, but we also had all these kids that wanted ABA therapy. And we were working really hard with the healthcare authority to kind of figure out how we can get children access to ABA therapy, even though the wait list for getting a diagnosis of autism is so long. And what we created was this term that's called Center of Excellence. And basically, any of the multidisciplinary diagnostic teams that are already in place with a psychologist and a developmental pediatrician, a speech, all the big tertiary centers, they're already center of excellences because that's kind of what they do. But we were trying to bring the training out into the communities, into the rural communities, and training pediatricians to basically be able to identify kids with autism that were really, really straightforward, and they would be able to write a prescription for ABA therapy so that these kids could get into services without having to wait another year for the diagnosis. We're still doing some of this work, and I think how that ties in with the, well, let's digress for a minute. So the Center of Excellence, and there, I have some information here on where you can find places in your community that are designated as centers of excellence that could help you with getting an ABA therapy prescription. So back to SMART, and that's where this all ties together, is most of the providers that were getting this training and Center of Excellence were not comfortable diagnosing autism at all. And so that's kind of the beauty of the SMART team, is that it's a multidisciplinary supportive process for assessing children. And so oftentimes on the SMART teams, you've got the pediatrician, the special ed director, you've got school psychologists, speech therapists, ABA therapists, the coordinator, and others that are interested. And we've tried to incorporate over the years some parents into these teams. So they're all working together to support the pediatrician in making that assessment. Why it works, it's local people with a passion. I mean, it started because the pediatrician and the special ed director were running into each other in the grocery store, and they're like, we need a formalized way to handle this. They know the kids in the community. There's a variety of agencies with broad knowledge. It's an open discussion, and what I've heard over and over is that it benefits not only the kids with autism, but it has really improved the collaboration between the medical providers and the schools. So that's very, very cool. And each of the SMART teams look a little different, and what they're capable, what their capacity is in terms of the age of kids that they're comfortable seeing, what kind of insurance they take. Up in Whatcom County, there's 3 different centers of excellence based on the 3 different main insurances, the state insurance, then there's Peace Health, and then there's all the others, private insurance. So that's kind of an interesting model. The funding for the coordinator looks different in each community. Some of them are able to actually give a diagnosis of autism that qualifies kids for DDA or other services. Other centers of excellence aren't able to do that. And some of the communities feel very confident being able to give a diagnosis. So other communities are feeling less confident, but they can at least kind of fast track the kids into services and into more assessments than they would necessarily have access to just waiting on a wait list. So that's kind of the last 9 years. And this work has been really, really exciting and oftentimes kind of messy. And it's often a moving target, but we've really learned a lot. We're continuing to work with Seattle Children's to provide Center of Excellence trainings out in the community, and we have one scheduled in April of this year. Providers who are interested in becoming part of the SMART process, but want more training, we have a collaboration with Seattle Children's Hospital, the Autism Center, where they can come for a day and kind of observe and be part of that to get more experience in training. We're working also really hard to try to put together it's a bi-monthly training for all the centers of excellence around autism called Echo Autism or Autism Echo, where we would do these trainings for the providers. They would be case studies that would really help providers feel more confident working with children with autism in their communities. And we're hoping to start that this summer. And we're going to start with all the Center of Excellence trained providers that are very, very hungry for more knowledge. And we also have a partnership with the Washington State Healthcare Authority to support a change in the Washington Code to make an autism diagnosis by a Center of Excellence provider also valid for DDA services, which is a huge that would be a huge deal. And then there's also a lot of work being done with the Healthcare Authority to increase Medicaid reimbursement, because getting the prescription is kind of the elephant in the room because there aren't enough ABA providers. But this is kind of a slow-moving elephant, and we all have a piece, and it's moving. And I was looking at trying to pull up some data from last year, and in 2018, there were only 2 SMART teams that were actually seeing kids. A couple of them were on hiatus until they got more funding. So of the 2 SMART teams, we had a total of 94 evaluations, and 28 kids received a diagnosis of autism in their local communities with providers that they knew. So, why does it matter to me as we talk about inclusion? And what I didn't say at the beginning was that I am a parent of a 18-year-old son with autism, and we just transitioned him. I just got guardianship of him, and he's having a really hard time finding peers, finding his people, and so I've often thought that moving to a smaller community for me would be better for him, because he might be able to get a job, he might be able to live independently, he might be able to drive. But I've stayed here because that's where the services are. And I wanted to share a story as we close on from a parent from the Autism Task Force in Grays Harbor, which is way out there, and how this work has affected them. And so in December of 2017, my daughter was referred to Mary Bridge for an autism evaluation. It took a month for verification that they even received the referral, then 7 more months for a call back to schedule the first appointment. I was dreading the long wait, the long drive to and from appointments, and the anxiety my daughter would have to have being tested in such a busy building. Lucky for me, the Autism Task Force swooped in and changed my negative feelings about this whole process. Within 1 week of receiving a referral for the task force, I had been contacted and scheduled our first appointment for the stat testing. We met less than 10 minutes from my home and were welcomed by only 2 smiling faces as we walked into the door. The coordinator was open to texting, to set up our next meetings, and even if I just had a question. Within a couple short months, we had finished modules, started OT, and I felt like I had the greatest support team right here in my neighborhood. I was so impressed with the comfort my daughter felt working with this team, I started recommending the task force to every family I knew with an autistic loved one. I never expected the road to a diagnosis would be paved with such understanding, eager, and helpful people. The task force is just what a family like mine needs. How can we ask an anxious child who is so easily overwhelmed with everyday life to travel, sit in a busy waiting area full of stimulants and strange people? Luckily for me, I never had to ask this of my daughter, and I'm so grateful for that. And so that, to me, is why it matters. Thank you. I also have my contact here, so if any of this was interesting and you would like more information on how you can get involved or connect with your people, you're free to contact me. Thank you. And I think you're next.
You're up, Fred. I'm up. Laser thingy. Okay. All right. Hey, everyone. My name is Fred Shic. I'm going to talk to you about autism and technology in review in 2018. So just briefly, I just want to give you a little bit of a history of where I've come from. So I started my career out of school working in video games, because that's just kind of what you do with some computer programming skills, and decided that it wasn't for me, and I started up a stint doing some research at an MR spectroscopy laboratory. Decided I really liked research, found out that you need to get a PhD, also found out it doesn't matter what your PhD is in, so computer science again. Joined a computer science lab, working under Brian Scasoletti in social robotics, and from there, as I was programming the attention system for this baby robot, met Kasia Havarska, who really brought me into the field of autism research. It was kind of a trade off some data for helping her with some experiments, and she just naturally became a mentor for me. And here I am 15 years later talking to you about video games. So that's just how it works. I have a lab called Seattle Children's Innovative Technologies Lab. We focus on the creation of everyday technologies to help individuals with autism. So I'm going to talk to you about autism research, and this is a little bit different from the types of technology, autism research in technology, which is a little bit different from technology that's used more clinically. But my focus is specifically in everyday technology, so that's where we want to go. But the research side of things makes it a little bit different as compared to thinking about what you would use for practice, where in many cases what works just overwhelms what works for this individual. That's what works for this individual. So what we're after is trying to figure out those general principles that can inform treatment and diagnostics and phenotyping, all these things on the right-hand side. But we start with technology development, and as a computer scientist by training, that's usually where I start thinking about things.
And then we ask these questions that go through this layer of experiments, and then hopefully at that point we get enough information that helps us understand where to take this in terms of clinical applicability. Technology research is in autism. Autism technology research has just been expanding, exploding over these last few years. Things have really changed in the last decade. I mean, they're moving incredibly, incredibly quickly. So much so that it's almost impossible to keep up. And I'm going to use that as an excuse as to why I'm just going to show you a few studies and just pretend that that's the entire field. It's not. The entire field is changing in just a massive way, kind of almost reinventing itself every year, maybe every week. So the first study I'm going to talk to you about really kind of captures this idea that how fast things are changing. So this is an example of a system that comes out of Stanford, Dennis Wall's lab, which is called Superpower Glass. Now, seems like a pretty lofty name. This is not a name that his team chose. This is what the kids who were using the system chose as the name for this system. And so Superpower Glass basically lives atop of Google Glasses. And if you don't know what Google Glasses are, they're essentially these kind of futuristic, computerized goggles that essentially have a camera in the center. That camera is fed into a little microcomputer on those glasses. There's also a little LED display in the upper right-hand corner that's pretty unobtrusive, so that someone who's looking at you isn't really paying attention to what's being shown in your eye, but you can see it very clearly. And there's some bone-conducting microphones that basically can send audio to you but not announce it to everyone else. And so what he did with this system is he basically used that camera in order, and that the computer that was on Google Glasses to basically be able to detect faces, and then when those faces were detected, basically translate them into what type of emotion was being shown, and then used the visual display, heads-up display, and the microphones in order to convey what motion that was for these kids. Now, this is very preliminary study, and I'm going to just tell you a little bit about what the experiment looked like. But if you think about it, and this question of what inclusion means to someone who develops technology, I mean, I think that this really captures some of that essence, right? It's not about, like we're not in there necessarily saying that's this is a technology that can kind of move you from A to B. We're also saying that this might be technology that can eventually help augment your capabilities, give you access to the types of information that neurotypicals have access to in a day-to-day basis, and allow that information to be provided to you through an alternative signal that can be very accessible to you. So that's the dream of it, but it's not actually what happens in this research, but that I think is the broader vision of what this type of technology can provide. So in this particular study, as I mentioned, a child is looking at a person, and the Google Glasses is analyzing the facial expressions and saying, well, this is someone who looks sad, and this is clip art, so this is not actually real performance, right? So each of the emoticons is associated with the sound. It's also associated with a specific color, and that way, over time, it's hoped that the child can basically just peripherally sense what emotion is being shown there, so that they can get that information very quickly. And so this study really involves 14 families, about 10 years of age, IQ about around 100, and this is roughly a 10-week study. And essentially what the families were asked to do was to play these games with these Superpower Glass goggles 3 times a week for 20 minutes a session, and they would play these games like what they had called Capture the Smile, where the child is challenged to basically elicit an emotion from their caregiver. And so, you could imagine like this is something like, happy. And so the idea is that the child does something that makes, his mom happy, maybe a big smile, and then the mom smiles, and then the computer recognizes that there's a smile that's occurring. You get some like, ding, you did it right, it's great. Originally, I started with the angry condition, and I just thought, like any example I could come up with wouldn't go over well. So, so this is kind of where this technology is going. In this very limited study, which had they basically found that there was improvements in emotion recognition in this game that was kind of embedded in the system, and that's not surprising because you're trained to you're basically testing on a game that you're being practicing on. But they also saw decreases in social deficits as rated by a parent questionnaire. And those changes weren't related to the intensity, that's the amounts that you're using these glasses, or your IQ, suggesting to them, they wrote that it suggested to them that this was very general. And 12 of the 14 families reported increases in eye contact. Now, this is kind of a limited study, and unfortunately, this is where a lot of the technology research starts. It has to kind of start here, small studies, limited scope. There are follow-ups of this that I believe are coming out, and I think that we'll see greater and greater evidence for this type of work, but this is kind of like the combination of a feasibility, initial plausibility of some type of efficacy happening, so kind of exciting. No control group, right? Like, I'll just point that out. So it's exciting, but wait to see more of where this technology goes. Some other work that we've been involved with, this came out of the NSF expedition in socially assistive robotics. This was actually work that we did at the Yale Child Study Center. Brian Scasletti and Lauren Baccafuso, Qinming Huang, all these great people. So robots are something that for a long time we've been excited about in technology research. We've been talking about them for over a decade, close to 2 decades at this point. And the reason why we've been so excited about them is because robots are a technology that for some reason, perhaps for the obvious reason, many individuals with autism just gravitate towards these. Many children love interacting with robots, think that they're really cool. And as far as I know, that's still true today, even though the number of robots in our lives are actually increasing, which is kind of neat. By and large, though, the research that we've seen with robots are kind of these small studies, sometimes case studies, really focused on technology, and often remote controlled or really contrived laboratory experimentation. There's a real question, though. If we want to use robots and we want to see these actually have an impact on individuals' lives, and we want to turn this into a tool that can actually provide benefit, we might need to think about how do we actually sustain engagement with the robot, and that's a question that hasn't been really addressed. And so this study involved putting this robot, this cute robot called Jibo, that comes out of a company created by Cynthia Brazil, who is at the MIT Media Lab. And what Jibo did was basically facilitated interactions between parents and the robot and the individual with autism, and also played a bunch of different types of games to encourage some types of interactions, but also to work on skills that were believed to be associated with competency, social, communicative, emotional competencies. And so, again, small study, 12 individuals, but the things that were special about this study was that it was conducted fully autonomously. So this was a robot that was put in the home for 30 days with no interference from a experimental team. And so this basically meant that all of the information about what the robot needed to do in what situation had to be embedded in that robot. And so that's at the point that we are at now. Now I have to say that we're not there yet. Right? Like, we don't have Rosie the robot. But what we do have is kind of some experiences suggesting that it's possible. We can put these robots in a home, and it's a very challenging environment, right? Like, lots of things going on, lots of complexity, people knocking things over, cats knocking things over, because that's what cats do. And we're trying to learn from these experiences to figure out, like, what are the lessons that we can use in order to kind of build the next generation of these systems. And so this particular system was built to be adaptive, so it adapts to where a child is, and so that way it can try to kind of maintain that sweet spot of engagement. And also the entire study was wrapped around generalization, and so there was other tasks that were not, oftentimes we see like performance about how you did inside of the tests or the different games that are embedded into the system. And here we also had kind of the wraparounds, how did the child improve as measured by kind of a directly assessed skill by a clinician. So this is just an example of, there's a bunch of different games, and I'm not going to talk about them individually, but there was definitely some improvement over time as we expected. Parents said from the beginning to the end of the intervention for them that there was improvements in eye contact, initiations of communication, response to communicative bids, both with parents but also with others. And then we had this measure of joint attention, which was a series of naturalistic probes delivered to the child to measure joint attention responses. And we saw a kind of a nice improvement between day 0 and day 30, but that wasn't maintained into day 60. And so, nothing is solved, right? This is just the beginning, but I think that it's just showing like the promise of this type of system. Now, thinking about what this means in terms of like building these systems, I mean, you can imagine in places where, of course, and this is something that everybody in technology in general is very careful to say, is that this is never in no way meant to be a replacement for anything related to kind of clinical expertise. It cannot replace clinical expertise, but what this can be is tools that can be kind of put into the bag. What type of bag am I thinking of? It's like what's that? Toolbox. Thank you. It's a tool in your toolbox. I always look to Sara, and she tells me what I'm forgetting. This is how we're thinking about the technologies. But you can think about a system like this, right? 30 days autonomous provides, this is not providing a comprehensive education, no way about that. But it's providing some skill learning. And the idea that you can take a robot, ship it to someone, open it up, maybe, that would be the dream, right? Just put it down, provide instruction. Someone's monitoring this. Someone's monitoring your child's progress, telemedicine, telehealth. This makes it possible, but this idea that this robot can capture that engagement, that makes that intrinsic engagement with the robot and turn that into something that promotes learning, I think that's really exciting, and it offers a lot of different ways that we can provide access to kind of new types of interventions for individuals who wouldn't typically be able to access those things. Am I totally over time? I can't tell. 10 minutes, all right. So kind of along these lines, how did this robot do all the things that it was able to do? And a big part of it is, there's these games that were kind of pre-scripted. So, in some ways, a lot of cheating, right? Like we know what the constraints are in the environment that we created for them. In other ways, we are also using different types of computer vision types of algorithms to understand the world. And this is an example of how, honestly, I feel like computer vision is revolutionizing our ability to think about out of the box about getting direct measures of individuals with autism, especially children. And so this is work that comes out of Duke, Helen Egger, Jerry Dawson, and it's a system called Autism and Beyond. And the idea is that this is essentially using your mobile phone, using the camera on your, I broke this. This is what happens when you give me technology. It's when it's basically using the camera on the phone together with the processor on the phone, on a mobile, iPhones actually, in order to extract features about what a child is doing that's kind of looking at the screen, and using that information to understand something about autism risk, and is specifically using these type of experimental probes, these different types of content on the screen, in order to ask the question of different types of question. Now, Sara earlier mentioned that we've been seeing these really big studies of autism, 400 individuals, and that truly is something in a totally different ballpark, because those individuals are looked at deeply. But by the numbers, right, a big study, 400 individuals. This is a study deployed in 1 year that reached 1,756 individuals, right? So you deployed an app, and this was built atop ResearchKit, and from this, together with some survey data on basically the MChat and questions like, does your child, basically self-reported child having autism, was able to look at, what is the emotional response to a bunch of these videos that are supposed to elicit some types of kind of emotional facial expressions. And from this, was able to show that those children who are at higher risk for autism showed a greater preponderance of neutral emotion when viewing these different types of clips. And specifically, could isolate which types of probes kind of had a differential impact on these children. So that I think is summarizing, just how fast things are moving in terms of our ability to reach large populations with different types of technology. Now, this is kind of a hybrid study. This is also work by Jerry Dawson, Kathleen Campbell, Kim Carpenter, and others. And this is kind of a hybrid system that kind of uses the same type of technology. And this was, by contrast to the other study, which is basically remotely deployed very, very broadly. This was a study that was done in a laboratory involving 22 toddlers with autism and a comparison group of 82 children without autism. And what this particular task did was, this was meant to study orienting to name, essentially. And so you had this tablet sitting in front of the child, and the child was sitting on the caregiver's lap and looking at this video that was playing, and of course we're recording the entire time. And then experimenters in the back, and there's a cue that occurs every once in a while that basically tells the experiment sitting in the back to call out the child's name. And what you're interested in is using that camera just to detect that movement of the head, that orienting. And so from this study, she was able to show over here, like if you look at the number of times that the children with autism versus the children who were in the control group looked oriented any amount of time. They looked pretty similar, but if you look at the number of times that they looked multiple times, you can see this really big gap. And so this is kind of like thinking about how can we build these technologies to support remote diagnostics, still involving people, but involving kind of classic probes that we associated with the phenotyping of autism, or the phenotype of autism, especially at this age. So simultaneously, as we're looking at all of these kind of new technologies, there's a lot of research that's also considering, how are technologies right now being used by individuals with autism? And so a recent survey of 472, this is self-report, 472 high school students with autism asked the question, well, how are you using technology to support your learning in schools? And I thought that this is kind of a very interesting perspective because, for the most part, a lot of the research focuses on excessive screen usage. And we know that that's the case, that individuals with autism over, a broad age range are more susceptible to excessive screen media use than their neurotypical peers. It actually was the case that many of these students reported that they're using these technologies to really support their scholastic achievement, right? And so they're using these things to look up things on the internet, to type up things, make presentations, but also, you look at this list of things that they're using technology as, right? These are things that kind of allow, if there's any type of executive functioning issues, it allows you to offload some of that responsibility onto these systems that can help to support function. And in terms of the positives, 87% of those students said that it made learning easier, and 85% said it made it more fun. They liked the fact that they could reach their parents, and they also used technologies to relax and to play with friends. And in terms of relaxation, oftentimes this was just as simple as kind of listening to music, right? And getting into a safe spot that they could kind of tune out all the complexities and the chaos of what was around. A lot of uses of communication using these technologies, and there were some indications that communicating through these type of technologies was a lot less stressful than these face-to-face interactions, and so for that reason, possibly made them more successful at communicating overall. So thinking about the advantages, but there's of course disadvantages, a lot of distractions. 58% of the students said, like, this is actually, like, there are times that I'm going to lose focus because of the technology. And of course, not all the classes would permit the uses of technology. And so these authors had kind of summarized, like, yes, these are things that are basically improving independence, and it's facilitating social opportunities. It's evidence that it's reducing stress and anxiety in these scholastic environments. And they also noted that this work by Wong et al. In 2014 really suggests that technology-aided instruction is evidence-based at this point. Like, there is evidence to suggest that this is really effective in kind of supporting teaching. But they noted that essentially teachers and institutions need to facilitate the opportunities to be able to use these technologies, and that could mean more coaching and supports for how technology can be incorporated in classrooms. And also, but at the same time, we don't want to go all the way to the, like use your phone whenever you want. It really, there needs to be a shift on towards focusing on how to teach individuals with autism to use these technologies responsibly, and that's also kind of like, how do we get to that? What do we do in order to answer those questions? These are things that we have to answer. Lots of other things that are happening in the field. I really enjoyed this paper. This was a conceptual paper based off of an interview of 12 adults with autism, asking the question of what are the spatial needs of individuals with autism, and how can technology promote that? And these are questions like, what does your living space need to look like? How do you conceptualize your home? This was asked a question of draw your immediate environment. The immediate environment that many individuals with autism drew was dominated by their home. Like, this is their safe spot, right? And so, and you can see what's happening outside of their home, right? This car is on fire. So, like that might summarize the external world versus this internal world in terms of the safety of this house. And this idea of like thinking about the lived experiences of individuals with autism and using that in order to inform our decision making in terms of how research should go, I think it's really kind of a good trend in terms of thinking about how we should develop our technologies. Again, there's also a lot of, we're seeing a lot of crystallization of the field, like a lot of things that we've been talking about for over a decade, like computer-assisted instruction for emotion recognition in autism. There's, now there's 8 studies that kind of use the same general types of approaches so that they can be aggregated. And yes, it suggests that these instruction techniques using computers are really effective, especially if they incorporate coaching and focus on face features. So basically an explicit mapping of like what the face is doing and how that maps onto emotions. Lots of different places, like I said, wearables, virtual reality, augmented reality, video games, robots, lots of robots. Biomarker technologies, taking the things that we're learning in what we might consider to be more bioscience or basic science types of fields and turning them into technologies that can actually produce some type of practical output that can help with treatment monitoring. Speech generating devices, AACs, undergoing a revolution in terms of the evidence base for those. Lots of more controlled trials occurring. And then there's these things that we don't expect, which is, I think, what makes us really excited as technology researchers. This is a system called Alter Ego. So it's a bunch of electrodes that basically kind of cover parts of your face and your neck. And what it does is it allows you to map your sub-vocalizations. This is like the sound that you make when you're reading aloud to yourself, and turn that into communicative signals that can actually be conveyed to others. Now, they developed this so that people communicate silently with each other. But you can imagine that for the subset of individuals who are non-speaking, right? Not non-verbal, but non-speaking, with a distinction made between those two, that this type of technology might be really valuable. Like, this might provide some way of communicating and thinking about augmenting the capabilities of individuals with autism. I think that this is an example of, some of the science that when we look at this, even as people who are computer scientists and engineers, we go, oh, this is cool. And then we read the paper and we're like, yeah, I could do that. And so that's the thing that makes it so nice to be in this research field. Everybody is sharing, everybody's telling you how they build these things, maybe not down to the nitty gritty, but enough so that we can all move the field forward together. And so it's a really wonderful place to be. Finally, coming back to this pipeline, this translational pipeline, I mean, it really, this is the point, isn't it, right? Intervention, what we can do to make lives better. And I think that that's where we want to end up with all of these systems, right? Whether we're talking about a social model or a medical model or whatever type of technologies that we're using, whatever perspectives we're using, this is the goal, to take that technology and turn it to something that will change lives. I want to thank my entire awesome lab. We're a small lab, and they're great. Awesome collaborators, Sara, Rafe, other people in the rooms, Gary, all of you guys. But what I would like to say is that we're in the midst of figuring out, when we say we could do that, it's rapidly followed up with, but we don't have time to do that. And so we need advice, right? We need perspectives. And that's one thing that I'd like to say is that if you'd like to be involved in our research, if you'd like to provide us feedback, advice, join in a focus group so that you can help us develop the next generation of technologies that are valuable, please contact us. We would love to speak with you.
Ever since you asked me to think about what inclusion means to me, I've been thinking about the sitcom Cheers. There's this song that comes on at the beginning that talks about at the end of a day, you all want to go to a place where everybody knows your name. And when I think about inclusion, that's what I think of. What I want for my children is for them to have a place in our neighborhood where they can go where everybody knows their name. And I want them to have a place where they can go and play and work and thrive and not have to drive or take 3 buses 2 hours away in order to be accepted in a community. So that's, to me, that's inclusion. I'm going to speak to you a little bit about what we do to overcome barriers to access and reduce health disparities by maximizing health and disability benefits. And I've got a lot of notes to keep me on track, so I will promise to stay on task. Washington Autism Alliance and Advocacy is a personal advocate and legislative champion for children and adults with autism and other developmental disabilities. Our mission is to ensure that children and adults with autism have every opportunity to thrive in their own communities. We do this by helping families and individuals access insurance benefits, effective services in schools, and community-based services regardless of their financial backgrounds. We work diligently to bridge the gaps between many health and education policies that exist to serve children and adults and the educators, politicians, and medical providers that want to support them but don't always succeed in doing so. We provide civil legal aid and family navigation. Oh, okay. Aha, very fancy. What that means is we provide guidance, counseling, coordination of care, training, and identification of resources so that families and persons with disabilities can access effective services and socially significant programs. We also offer low-cost and no-cost community services. This includes community-based, in-context social learning and peer social communication portals so that families and persons with disability can connect and share experiences and feel less overwhelmed by the intensity of living with autism and the related intellectual disabilities. We also lobby for legislation that directly supports and improves the health, safety, and education of children and adults. We also make sure to connect the dots so that the policies are actually implemented to support those in need. These are our numbers at a glance. We are a very small but mighty team of attorneys, paralegal, advocates, and parent partners, and we have a statewide footprint. Some of what we advocated for in 2018. Applied behavior analysis is a form of behavior therapy that is frequently prescribed for people with autism spectrum disorders. ABA therapy providers and receivers were plagued with inconsistencies of coverage and reimbursement for many years. So in 2013, a coding change application was submitted to the American Medical Association, and a set of temporary codes were developed to standardize the billing and repayment process at that time. The AMA developed these temporary codes, and it was a great start. However, there are new codes there were 8 new codes that were just released and go into effect January of this year that are going to be significantly improving the way billing and reimbursement is processed as the health plans are going to be adopting them. Employment services help clients find and maintain jobs that match their goals and skill sets. Community inclusion helps clients develop skills, foster independence, and form relationships with non-disabled peers. Reimbursement rate caps are set in such a way that they incentivize only independent in individual employment. $75 an hour versus $35 an hour. Also, additional funding and support is only provided to clients who access individual employment. In 2018, the Joint Legislative Audit and Review Committee analyzed client data from everyone who accesses supported employment in the state of Washington and found 82% of all service expenditure in the state of Washington goes to supported employment. However, 80% of individuals with developmental disabilities are unemployed. Of the people who are employed, they work an average of 47 hours per month and earn about $583 per month. There's only 672 people statewide that earned a living wage. The other interesting fact that the report pointed out is the supported employment agencies earn an average of $950 per person per year more than the people with developmental disabilities. That's over $65 million more that the agencies earn than the people with developmental disabilities. The auditors had 3 recommendations. One, to develop some guidelines that will measure the quality of life outcomes for people with developmental disabilities. One, to ensure that clients also are offered a choice of community inclusion and report back to the legislature on its efforts to strengthen and expand community inclusion programs. In 2015, we saw through passage a law concerning restraint and isolation of students in public schools. This law provides that isolation of any student is only permitted to control unpredicted, spontaneous behavior that poses an imminent likelihood of serious harm, and that it may not be used as planned behavioral intervention. It also requires very specific data reporting. We've now had 2 reporting cycles from this law, and what we're learning is some schools are over-reporting and some schools are under-reporting. By over-reporting, I mean some schools are reporting a student being isolated in the athletic field. So in response to that, OSPI is developing a webinar to train school districts on the reporting requirements. But another thing that we're seeing is some schools are not using trauma-informed, research-based interventions for behavior management, and this is leading to increased incidence of restraints and isolations and students and staff getting hurt. And in some of the next slides, I'm going to talk about what we're going to do to address this. Continued barriers to access, Amy touched upon this. There hasn't been a Medicaid rate adjustment for behavioral health providers since 2007 in Washington state. That means screening, diagnosis, and treatment of autism is often considered charity care by all providers. The red is Washington state rates. This is just one type of behavioral health provider. So the red is Washington's rates. It's the lowest in the nation. The orange is the national average. The green is TRICARE, which is comparable to what private insurance reimburses. It's 2.5 times the rate of Medicaid. It's no wonder that private care insurance plans have much more robust networks than those of managed care plans. So what are we doing about it, and what's on the horizon for us? This is a very tall order. Let's unpack it one by one. A key component to improving a person's health is by improving insurance coverage. What the payers are telling us is few primary care providers are willing to serve people with autism and developmental disabilities. Without effective screening and prescriptions for care, a person with a developmental disability can't begin to access care. By training primary care providers on how to support a person in their practice, we can dramatically improve that access to care for people with developmental disabilities. Most people with autism have psychiatric symptoms in addition to autism. According to the 5th edition of the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, I feel funny saying this in front of Dr. Stobie, about 70% may have another mental disorder, and about 40% have 2 or more such disorders. However, none of our current university programs that train BCBAs offer any education or coursework in human development, child development, or abnormal psychology. We believe a hybrid program that allows graduates to be duly licensed as behavior analysts in addition to mental health providers is the most logical approach to crisis stabilization and support for complex behavioral and mental health needs. We are advocating for such a program at Washington State University Department of Psychology. Remember, I was talking about those schools that are not using trauma-informed research-based practices. In Washington State, our schools don't have a way of hiring board-certified behavior analysts unless that person is also certified as a teacher. However, none of our schools, none of our education programs are preparing their graduates for this dual certification. So the only way a school district can hire a BCBA is if that person is also certified as a teacher. There's few BCBAs around the state who are duly certified. Education staff associates work in schools to serve as school psychologists, occupational therapists, counselors, speech and language pathologists. We think this is an avenue by BCBAs getting certified as ESAs. This is an avenue for school districts to be able to hire more BCBAs, and it gives them the ability to work in schools. Again, what we're hearing from payers, parents, and providers alike, there's a tremendous shortage of the paraprofessionals that work directly with clients with autism. Even though there's only 40 hours required of training for these professionals to be licensed and credentialed through the Department of Health. However, statewide, in every community, we have a pretty robust network of community health workers. If we trained these community health workers to become certified behavior technicians, I think we can dramatically improve that outcome. We have a pledge from the largest managed care organizations to help us take this on. We continue to grapple with the fact that home care workers that provide MPC, Medicaid personal care, and help individuals with disabilities with activities of daily living are not adequately trained and prepared to work with people, especially children, with autism. They're mostly trained to work with people with physical disabilities and end-of-life care. And their pay structure competes with them getting work in a fast food restaurant. We will continue to advocate for better training and better pay structure for these workers. I know most families are unable to fill their hours and find workers to fill these positions. How many parents in this room have been referred to a provider and have faced a 10-page intake form? And then you go to the next office and you're given another 10-page intake form. And then the next one. And then the next year you have to do the same thing over again. And then you do this year after year after year. I have a 22-year-old. I'm still facing these 10 pages. And I'm trying to help him be more autonomous. So I'm trying to help him fill these forms himself. Cheyenne, when did you first sit unassisted? He says Thursday. It's really hard to fill out these forms and update them. We are working on a form that is going to be accessible online. It's going to be filled once, and it can be downloadable. It's a universal form that can be translated to hundreds of languages. In-school ABA, medically necessary ABA is very different than the services that are offered under an IEP. And medically necessary ABA is covered by both health plans and Medicaid. Yet most providers don't have access to students during school hours. We've been following a case in Hawaii, and I want to read a few sentences out of the complaint. It's an ADA case. It says, the Department of Education's refusal to accommodate medically necessary ABA during school hours forces students with autism out of public schools. This violates not only ADA and Section 504, but IDEA as well. As a general matter, services that enable a disabled child to remain in school during the day provide the student with meaningful access to educational that Congress envisioned. We believe that by working with OSPI and schools, we hope to get a better understanding of what the barriers are so that students have access to medically necessary services during school hours. And finally, telehealth services. We've heard from everyone that in rural areas, there is very, very limited access to screening, diagnosis, and treatment for autism. By promoting telehealth, we can bridge geographic limitations and increase access to providers. Amy mentioned Project Echo. That is a telehealth portal. Some of the topics that case-based learning and discussion with can offer is medical conditions for children with autism, co-occurring psychiatric concerns, underlying medical concerns for people with limited communication, screening and referral for best practices, supporting feeding and sensory concerns, also successful office visits and lab visits. If you would like to join us as an ambassador or an advocate, you can reach us by phone, email, or through our website. We'd love to hear from you. Thank you.
Thank you, Arzu. Okay, everybody. Well, thank you very much. We have already gone past our time, and I know I promised a time for questions. So I think what we will do is if you have specific questions for any of our four people, or me, if you had some random question about the three things that I said, then please come up and ask. And we do have people who are on Facebook who might have a specific question. And if you guys wouldn't mind just kind of trying to answer that question before we go. I'm very excited about this year's whole series. We've got an amazing lineup of folks coming to share their knowledge and to have great discussions. So I really hope to see everybody here next month and throughout the year. And if you're watching from home, I hope you keep watching. So Stacy's going to say something.
So we have a question for you. Yep, for you. So if an adult is interested in being contacted about research studies for technology to support adults with autism. So if they're interested in kind of joining some of those studies with the technological robots and different cool things, how would they find out about those studies?
It's a very good question. I think that there's, I think in general we need to be better about figuring out portals that we can use in order to make knowledge about our development for experiments more available. I struggle with this a little bit because we usually go to lists to get, recruitment information. But, and I'm actually not certain. I mean, Sara, do you have some sense of how we would advertise broadly for recruitment?
So I know that there's a couple of sort of national recruitment networks. So things like the EN network has sort of recruitment portals that can get people into sort of nationwide repositories and registries that are then accessed by researchers who are looking for individuals who might join them in their participant group. Seattle Children's has a research registry as well that is open and can be accessed, and we can certainly get that information up so that people can find that number and that email to contact. We'll put that on the in the information with the talk. So I think that there's kind of a lot of that access, though, as you know, Fred, just comes to individual investigators of people who are interested, who then sort of try to make the contacts for that people out. So some of it's still word of mouth, but there isn't really a great way in many communities right now of types of research registries, and that's Seattle Children's has taken that on, so there is one there. But if the person who's asking the question is sort of at a different location, it's a little bit more legwork of trying to find the nearest autism center and then trying to find, like of going down a search to doing that. But I don't know if there's any multi-site sort of technology studies that are going on right now.
I was actually just thinking that, if this is something, it actually kind of caught me by surprise because we have been very successful in recruiting for studies and running studies. But by and large, like this general deployment of information, saying like we have a study running, has been very low yield in terms of getting participants in. But maybe that should change. And where can we put that information so that it can be more, generally accessible to maybe everyone in Seattle or everyone in King County? I mean, how would we set that up? Who would be the organization to take that on? That's, I think, the question. Does anyone in this audience have a idea? Maybe we could add everyone to the Seattle Children's research registry. Maybe that could.
I don't. At a nationwide level, there's really isn't a sort of a research registry, and so often it is just making the connections and knowing how well that one researcher or that one program does their own outreach is usually how it found it. So it's an interesting question. There should be a technological solution for this, Fred.
We should think about how can
we'll work on this.
more
We'll bring it up at
organized.
our next lab meeting.
Yeah.
How's that?
Yeah.
And we'll see if we can
Sounds
find a
good.
solution.
We'll do one more question
Thank
here,
you.
and then if you have a question, you want to talk about it.
How I've got my kids to be research lab rats for the
Through the UW research registry.
my kids have been the test subjects. And that's because I filled out a card when they were born and they had a registry and they just sent me a note saying, hey, would your kid like to test a vision test? And one of them was an autism test and stuff. So it was very interesting to do. My kids were tested.
And I think we use the autism, that UW research registry also to recruit from. But it's I guess it would be a little bit different. Like if you were to just list everything, but the problem is maintaining it, and then maybe that's the.
That's almost a separate office.
Yeah.
I have one quick question. I know we're running out of time. So this is regarding ABA. So when you're out there talking to family or to providers about ABA and they're wondering, learning how to write an ABA order, is there discussion around what who needs ABA? Because not everyone needs ABA. ABA it can help a lot of different issues, from skill acquisition to behavior challenges. But some people really benefit and need ABA. Others, it's not indicated. So how is that explained to the providers so they know how to discern who to prescribe it for and maybe who's not going to benefit from it?
That's a great question. And that is part of the training, because we realize that ABA isn't the magic bullet for everybody. That it's one in a toolkit, and that oftentimes there's other ways. And that's been some of the creative things that have happened in the rural communities. Is it isn't necessarily ABA isn't necessarily the first line, but because it's not available. Right.
Yeah, well, it's a very effective therapy for certain issues and needs. So I was just wondering if you said, a candidate for ABA might look like this, and I wouldn't prescribe it for a situation like this. That's good to know. Okay.
All right. I think we'll call it a night. If people have specific questions for any of our speakers, feel free to come on up. Thanks, everyone. We'll see you next month.